Good evening. Thank you once again for coming back for another class. I will be continuing with the drugs altering hormonal milieu under anti-cancer treatment. So, we are going to come to the second type, that is the estrogen. The second drugs are estrogen. The first drug we had seen last class was glucocorticoids, and in that we had discussed about prednisolone, which is widely used, and in some areas we go for using dexamethasone. Now we will start with estrogen. Estrogen is actually used for providing a symptomatic relief in case of carcinoma prostate. Estrogen, they are mainly used for providing a symptomatic relief in case of cancer prostate, and since it is an androgen dependent tumor. So in such kind of cases we go for administering estrogen. However, we can find that relapses occur, but still the life is prolonged. Relapses occur, but the life is prolonged, and they have been superseded in carcinoma prostate by gonadotropin releasing hormone agonist used along with anti-androgen. Alright, so now these estrogens, they have been superseded in carcinoma prostate by gonadotropin releasing hormone along with anti-androgen administration. Now in that we can also find that they behave as palliative. In the last class I had said palliative means they are not going to treat the disease, but they are going to behave as a symptomatic relief in such cases. So they are palliative and they provide a very good relief in primary as well as metastatic carcinoma prostate, and they suppress androgen production. Okay, that's why I said it will be mainly given, or it will be behaving, since this carcinoma prostate is actually androgen dependent tumor. So in such kind of cases what it does is it will be suppressing the androgen production through pituitary. And here the drug that we will be commonly using is phosphestrol. Phosphestrol we will be using here. Now this is preferred by some as it is concentrated in the prostate. It is concentrated in the prostate where it may antagonize androgen. Some areas high doses are required, and gonadotropin releasing hormone agonists with or without androgen antagonist are also preferred here when we go for administering phosphestrol. Okay, so phosphestrol is actually concentrated, or it is usually preferred because it will be concentrated in the prostate where it will antagonize the androgen, and high doses are required, and gonadotropin releasing hormone agonist with or without androgen and antagonist will be even more preferred in this kind of case. Now another feature about phosphestrol is it is a phosphate derivative of stilbestrol. Phosphate derivative of stilbestrol, and the dose administered here is 600 to 1200 mg intravenous initially, followed by a maintenance dose of 120 to 240 mg orally. Okay, so this is about the drug we use under estrogen. So estrogen, we go for administering, or we go for using this particular drug in order to provide a symptomatic relief in case of cancer of prostate, since it is an androgen dependent tumor. And this also behave as a palliative, since we said in the first class of the hormone administration that they are going to provide, or they are going to behave as a palliative agents. So it is a palliative agent, and it can be used in case of primary as well as metastatic carcinoma prostate, and what they do is they will be suppressing the androgen production through pituitary. And here we will be using the drug phosphestrol. Phosphestrol is actually a phosphate derivative of stilbestrol, and they are specifically used only for treating this carcinoma prostate. And the dose we go for administering here is 600 to 1200 mg intravenously initially, followed by a maintenance dose of 120 to 240 mg orally. And apart from that, here this phosphestrol, when we start administering, it will require high doses. So here high doses will be given, and gonadotropin releasing hormone agonist with or without androgen antagonist are preferred in this case. So this is about the second classification under drugs altering hormonal milieu, and it is estrogen. Under estrogen, the commonly used drug is phosphestrol. Moving over to the next drug, that is selective estrogen receptor modulators. In short, it is abbreviated as SERM. Selective estrogen receptor modulators. Okay. Now, selective estrogen receptor modulators, it is abbreviated as SERM, and they have a very good effect upon the particular cancer treatment agents, and they also behave as a palliative part. And the commonly used drugs over here is tamoxifen and toremifene. Tamoxifen and toremifene. Now, let's see what do we mean by tamoxifen. It is the standard hormonal treatment of breast cancer, can be used in both pre as well as post-menopausal women. Though aromatase inhibitors are also gaining prominence. Though aromatase inhibitors are gaining even more better role than this tamoxifen, still we use them. And the advantage is we can use it even in premenopausal as well as in postmenopausal women. In early cases, like when we detect any kind of cancers like related to breast and all etc., if it is in the early stage, we go for providing it as a post-mastectomy adjuvant therapy. It will be given in that. Whereas in case of advanced cases, it will be considered as a constituent of palliative treatment. Now, the response rates can be found to be higher in case of estrogen receptor positive breast carcinomas, but some, okay, I want to mention that it is in some estrogen receptor negative tumors, but high rates or response rates you can see it in case of estrogen receptor positive cases. It also is effective following surgery in cancer of male breast. Surgery in cancer of male breast. Now, it has been approved for primary prophylaxis of breast cancer in high-risk women. In high-risk women, it can be used as a prophylactic agent. And recurrence rate in ipsilateral as well as in contralateral breast is also reduced by tamoxifen, but the benefits of prophylactic therapy beyond 5 years are not proven. So outcomes may turn out to be worse. Okay, so in high-risk cases, we go for administering this as a prophylactic agent. However, the benefits of prophylactic agent, when it is being used as a prophylactic agent once it goes beyond 5 years, is not yet being proven. An improvement in bone mass due to anti-resorptive effect and in lipid profile are the other benefits of tamoxifen therapy. Improvement in bone mass due to anti-resorptive effect as well as in lipid profile. They are the other benefits of tamoxifen therapy. However, endometrial thickening. Endometrium is one layer of the uterus. Endometrial thickening occurs and the risk of endometrial carcinoma is increased 2 to 3 fold because of this endometrial thickening. Now let's see what it undergoes, or we are going to see its mechanism of action. Okay, so it is very effective when taken orally. It has a biphasic plasma half-life, that is 10 hours and 7 days. 10 hours and 7 days, and a long duration of action. Some metabolites of tamoxifen are more potent anti-estrogens. They behave as anti-estrogens, and the drug is excreted primarily in bile. In the remaining drugs, we had seen that the drugs were excreted either completely in urine or sometimes unchanged in urine, but here the primary mode of excretion out of the body is through bile. In case of male infertility, we can use as an alternative to clomiphene. Tamoxifen and other uses in case of male infertility, we can use it as an alternative to clomiphene. Now side effects. The side effects we can notice when we start with tamoxifen are hot flushes, vomiting, vaginal bleeding, vaginal discharge, menstrual irregularities, increased risk of venous thromboembolism, dermatitis, anorexia, depression, mild leukopenia, and ocular changes are infrequent. They are not frequent. Okay, the frequently occurring ones are hot flushing, vomiting, vaginal bleeding, vaginal discharge, menstrual irregularities, increased risk of venous thromboembolism. And infrequently found complaints are dermatitis, anorexia, depression, mild leukopenia, and ocular changes. It is considered, this particular drug is considered to be less toxic than any other anti-cancer drugs. So this is about tamoxifen. Now one more drug that comes under selective estrogen receptor modulators are toremifene. Toremifene. Toremifene is a congener of tamoxifen with similar action, uses, and adverse effects. So this is about selective estrogen receptor modulators, which is abbreviated as SERM. Okay, SERM, and we commonly use the particular two important drugs, that is tamoxifen as well as toremifene. And basically this will be this particular drug will be acting mainly on the estrogen receptor positive areas. Okay, so in such kind of cases we go for administering this. Okay, so with this particular way we will be going for using estrogen. Okay, so I will refresh what we had seen about tamoxifen. Tamoxifen is considered to be the standard hormone treatment for breast cancer, both in pre as well as post-menopausal women. And though it is being used here in many areas, even though these aromatase inhibitors are gaining even more importance. Now, if it is diagnosed, if the breast cancer has been diagnosed at an early stage, then this will be administered as a post-mastectomy adjuvant therapy. Whereas if it is in the late cases or in the metastatic cases, then it will be behaving as a constituent of palliative therapy. And a high success rates can be found in case of estrogen receptor positive areas, whereas in some or very few estrogen receptor negative areas, okay, negative tumors, they too have responded, but it's not very high. Only very few cases have responded to that. And also it is very effective following surgery in cancer of male breast. And it's also being considered as a primary prophylaxis or prophylactic agent in case of breast cancers, especially in high risk cases. This can be given. And the recurrence rate in ipsilateral as well as the contralateral breast will be reduced by this tamoxifen, but the benefits of prophylactic therapy beyond 5 years is not being proven. So sometimes if it is not proven, then it can turn out as though the outcomes are not very good with this particular usage. And apart from that, the other advantages we could find was there was an improvement in the bone mass due to this anti-resorptive effect as well as in the lipid profile. And another drawback of this is endometrial thickening will be taking place, thereby increasing the risk of developing endometrial carcinoma, which can be like increase up to 2 to 3 fold. And if you see how it acts in our body, now this particular drug is very effective when it is orally taken. It has got a biphasic plasma half-life, that is 10 hours and 7 days, and it has got a very long duration of action. And some metabolites of this tamoxifen, they behave as potent anti-estrogen, and this particular drug is excreted primarily in bile. And another use is in case of male infertility. Apart from clomiphene, it can be used as an alternative of clomiphene. Side effects: hot flushes, vomiting, vaginal bleeding, vaginal discharge, menstrual irregularities, and increased risk of venous thromboembolism. And the less frequent complaints that we can notice is dermatitis, anorexia, depression, mild leukopenia, and ocular changes. And it's considered to be less toxic than any other anti-cancer drugs. And another drug that we use under this selective estrogen receptor modulators is toramifene, which is a congener of tamoxifen, and its uses, its adverse effects, side effects, its actions, everything is similar to that of tamoxifen. So with this, I have completed selective estrogen receptor modulators. Now, moving over to selective estrogen receptor down modulators, we have fulvestrant. Now, fulvestrant, it is belonging to a class of estrogen receptor ligands. Okay, and it's called as selective estrogen receptor down regulators or pure estrogen antagonist. So selective estrogen receptor down regulators, they are otherwise called as pure estrogen antagonist, and they have been mainly used for the treatment of metastatic estrogen receptor positive breast cancer in post-menopausal women. In earlier case, tamoxifen, we said we can use it in pre-menopausal as well as post-menopausal women, but here it can be used only in case of breast cancers which are diagnosed in post-menopausal women, and that too these are estrogen receptor positive cases, and these people, they have stopped responding to tamoxifen. Okay, one more criteria is if this tamoxifen was administered to this postmenopausal women but they did not respond, in such kind of cases we start off with fulvestrant. And in contrast to tamoxifen, what this particular drug does is It inhibits estrogen receptor dimerization, so that estrogen receptor interaction with DNA is prevented. Okay, the receptor or the estrogen is being prevented, or this receptor is prevented from coming in touch with DNA, and the receptor degradation will get enhanced. The estrogen receptor is thus downregulated, resulting in more complete suppression of estrogen receptor responsive gene function. So this estrogen receptor responsive gene function will be getting suppressed, and this, along with its higher affinity for estrogen receptor, probably accounts for its efficacy in tamoxifen resistant cases. And it is administered as monthly intramuscular injection. It is slowly absorbed and has an elimination half-life of more than a month. Okay, so this is administered as monthly intramuscular route, and it is slowly absorbed, and it has an elimination half-life of more than a month. So this is about fulvestrant. Okay, so this fulvestrant comes under the category selective estrogen receptor down regulators. It's otherwise called as pure estrogen antagonist. And what it does is, it will be inhibiting estrogen receptor dimerization, so that the estrogen receptor interaction with the DNA will be prevented and receptor degradation will be promoted, or the receptor degradation will be enhanced, and thus the estrogen receptor is downregulated, resulting in more complete suppression of estrogen receptor responsive gene function. So this acts as a very good high affinity for this estrogen receptor action, estrogen receptor downregulator action, and this can be widely used in case of tamoxifen resistant cases. And also we need to remember, this will be used in postmenopausal women who have stopped responding to tamoxifen. And this particular drug will be administered once or as a monthly intramuscularly injection, and it is slowly absorbed, and the elimination half-life of this drug lasts for more than a month. So this is about selective estrogen receptor down regulators. So in this class I have completed, or I have touched on 3 things. I have spoken about the category called as estrogen, where we had seen the drug phosphestrol. Then we spoke about selective estrogen receptor modulators, which is abbreviated as SERM, where we have the 2 drugs like tamoxifen and doramifene in use. And lastly, we had seen was selective estrogen receptor downregulators, where we have a drug fulvestrol in use. I hope you like this class, and I hope this class is helping a lot. So next class we will be dealing with the next group coming under the drugs altering the hormonal milieu. Till then, take care. Bye-bye.